started. So can you see my PowerPoint presentation there okay?
Oh, yes, can do.
Yeah. Okay, so I'm Laura Ward. I work at the Scottish Learning Disabilities Observatory within mental health and wellbeing. And the work I'm going to talk to you today about is around anticlinergic burden in adults with intellectual disabilities. And this is done with a number of members from the SLDO, as well as Bethany and Nicola from the Robertson Centre, Christine from GGNC and NHS pharmacist, and Professor Gibson, emeritus professor at Aberdeen as well. So a bit of a mix of a team there. So just a wee overview. Oh, is that not working? There we go. Sorry. Overview of what we're going to talk about. Nothing too crazy there, so we'll just crack on. So first of all, in the UK, we still tend to use learning disabilities as the terminology, whereas worldwide kind of international literature uses the term intellectual disabilities, but they're fairly interchangeable for most UK work. So the World Health Organization defines an intellectual disability as a significantly reduced ability to understand new or complex information and to learn and apply new skills. This results in a reduced ability to cope independently, impaired social functioning, and begins before adulthood with a lasting effect on development. So this group of people with learning disabilities are very heterogeneous, but they do often have multiple physical and mental ill health that can necessitate quite a complex medication regime. So the second aspect of this talk is anticlinergic burden. So this starts with the use of anticlinergic medicines that are prescribed to treat a range of health conditions, including mental ill health, so depression, anxiety, epilepsy, and digestive problems, such as diarrhea and reflux. So these are drugs from lots of different classes of medication, and each have a different level of risk ascribed to them. And taking a few of these drugs can result in anticlinergic burden. So this is a cumulative effect of the drugs prescribed. Previous evidence is almost exclusively on older patient samples, about 65 plus. So as we get older, we tend to kind of collect long-term health conditions, and having 2 or more long-term health conditions is known as multimorbidity, which again often necessitates using multiple drugs. But people with learning disabilities experience poor health much earlier than in the general population. So for example, there's work from the observatory showing that the average 20-year-old with intellectual disabilities has a comparable ill health and multimorbidity to that of a 50-year-old from the general population. There are age-related changes to our body that affect pharmacodynamics. Think kind of the change in body fat, water composition, or blood-brain barrier, for example. And older adults are often more at risk of adverse drug events. But a lot of these issues around anticlinergic burden are important for people with intellectual disabilities at a much, much younger age. So even at therapeutic doses, people with intellectual disabilities are at risk of adverse drug events. And every prescribed drug leads to a 13% increase in having a potential drug-drug interaction of clinical significance. However, there's been a recent increase in literature around this area in the last few years, with much more kind of representative and robust samples, but it hasn't changed anything. It all shows anticlinergic burden is related to various poor health outcomes. And this is in patients or in people cohorts that include young and middle and older aged groups. So even the modest associations are really quite important. So this is kind of moving beyond the previous work that focused on older adults, inpatients in hospitals, and kind of all-cause mortality. This there's one paper recently by Peter Hanlon just well, 2 years ago, not last year, that has this increased risk to all-cause mortality, and these are in the biobank population, so quite a young, healthy cohort, really. And just this year, there was neuroimaging evidence that shows an association between anticholinergic burden and brain atrophy in cognitively healthy people. And this supports the robust evidence base around anticholinergic burden-induced dementia, which is evidence has clear implications for people with intellectual disabilities who might have a differing neurology from the general population in the first place, and also specifically those people with Down syndrome who are more at risk of dementias as well. So for older adults, there are clear recommendations to reduce anticholinergic burden where possible, and for certain health conditions there's a really good awareness of just not starting anticholinergics in the first place. So for example, overactive bladder patients, there's been quite a big shift away from prescribing anticholinergics and towards beta-3 adrenoceptor agonists instead. In general, geriatricians are aware of this problem and trying to reduce anticholinergic burden and improve the quality of life in older age patients. But there are similar issues in the intellectual disabilities population with relatively little awareness. So the work that we did here was quite exploratory. So we wanted to quantify the prevalence of anticholinergic burden in a representative sample of people with intellectual disabilities, and to identify where the burden is coming from with regards to therapeutic drug classes, individual drugs, and use of multiple drugs at the same time. So we used Greater Glasgow and Clyde NHS data, which was record linked by Idris and released to us within the Safe Haven. So everything's pseudonymized and linked by the CHI and then kind of de-identified once released. So our cohort is fairly representative. So GG&C serves about 20% of the Scottish population, and our data included all people with intellectual disabilities, so not just service users from specific centres, for example. And we identified the people with intellectual disabilities based on a previously created register from 2014, but we got prescribing data from 2009 to 2017. And we matched our intellectual disabilities cohort to controls based on age, sex, and SIMD. So SIMD is the Scottish Index of Multiple Deprivation, which is a composite measure of 7 domains such as income, employment, education, health, access to service, and housing or something. So regarding the anticholinergic burden, there's various scales with no golden standard used. So prescribing is obviously quite variable across countries. And for us, we use the anticholinergic risk scale, which is supported by the Scottish Government. And developed quite a lot. So the original publication was 2008, I think just 49 drugs, but this has been developed by various specialists and teams, and our list included about 170 drugs with each individual ranking. So the moderate risk drugs are ranked 1, strong risk drugs 2, and then the very strong risk drugs are ranked as 3. So anticholinergic burden was simply calculated by summing these scores. So the first set of results that I'll discuss focuses on this overall anticholinergic burden from across the whole study period. And the second set of results focus more on the more recent prescribing patterns of repeat prescriptions within just 1 year. It's a bit more of a conservative approach. So our results, who we had a fairly representative cohort of adults with intellectual disabilities, and these were matched 1 to 3 to the general population. So in the graphs, the general population are plotted in grey and the intellectual disabilities population in green. Because we matched on the intellectual disabilities population, we had more males and more people from more deprived areas. So it's also worth noting that in the general population, there are quite clear trends in poorer health in more deprived areas. But these health inequalities across our society in general are not that applicable to people with intellectual disabilities, namely because they're disadvantaged wherever they live. So a lot of the work that we do at the observatory, we see health inequalities in people with intellectual disabilities compared to the general population, no matter what their SIMD is or where they live. So as expected, the overall anticholinergic prescriptions were higher in the intellectual disabilities cohort with an odds ratio of 1.46. This isn't particularly surprising. We know that they have greater multimorbidity, which might necessitate more medication. But when we look at the specific rank of risk, so the 1, 2, or 3 for the specific drugs, we see that the intellectual disabilities group were twice as likely to be prescribed drugs with very strong anticholinergic risk. So unsurprisingly, when we calculate the overall anticlinergic burden, we see that a lot more people in the intellectual disabilities group have a higher burden than in the general population, so the odds ratio of 1.66. And these results are all adjusted for age, sex, and SIMD. So we know that within our group of people with intellectual disabilities, that most are taking some sort of anticlinergic drug, and almost half have a very high anticlinergic burden, something that we know is a risk factor for various poor health outcomes. In the general population, the older age categories had higher anticlinergic burden, but this was high for all age categories of the intellectual disabilities population. So we had this greater group difference for the younger age groups. So the 17 to 24-year-olds with intellectual disabilities were almost 3 times more likely to have a high burden compared to their peers. So those odds ratios are plotted in the graph below, just to give you a feel for across the age groups. When we looked at just the intellectual disabilities group, we see significant differences between the sexes. So women were 20% more likely than men to have high anticlinergic burden. And the risk of having this high anticlinergic burden starts at around 45 years plus, with an increasing risk for each kind of 10-year age band. This is worth noting, as we know for the general population, this age-related risk is about 60 to 65, but the intellectual disabilities cohort is 20 years earlier. So this reflects the evidence and the things that we know around the health inequalities faced at the moment. Lastly, there was no meaningful pattern regarding the deprivation, and again, this reflects that what we've previously seen. So when trying to identify exactly where this burden was coming from, we used quite a conservative approach of only looking at the drugs within the most recent year of data, and also only looking at the drugs that were prescribed at least 3 or more times, so kind of the more long-term medications. So this provided us with a smaller subgroup of kind of 38% intellectual disabilities from the original group, and then 24% the general population. So there were quite clear differences regarding the prescribing patterns when we looked across the different therapeutic drug classes. Adults with intellectual disabilities were prescribed more central nervous system drugs, gynecological urinary tract, musculoskeletal and respiratory system medications, and the general population were prescribed more cardiovascular, infections, and endocrine system prescriptions. Overall, anticlinergic psychotropics had the biggest group difference, with people with intellectual disabilities being twice as likely to be prescribed psychotropics. And when we looked at individual classes, we saw that people with intellectual disabilities were being prescribed more antipsychotics, anti-epileptics, anxiolytics, hypnotics, and that the antidepressants were comparable. So just to give you a bit more of an in-depth view of the results of these different psychotropics, These graphs have got the intellectual disabilities population in solid navy blue and the general population in the dashed black line. And these are the regression models, predicted probabilities of being on each class of psychotropic, but essentially the higher result, the more likely they are going to be on that drug. So you can see from the top left graph that the prescribing of antipsychotics in the general population decreases from young to older adults, but for adults with intellectual disabilities, this actually increases and it peaks at 55 to 64. So the next set of results relate to the use of multiple medicines. So polypharmacy is defined differently, kind of depending on what you're looking at. But because we're focusing on anticholinergic prescriptions, we classified polypharmacy as taking 2 or more anticholinergic prescriptions. And we also looked at psychotropic polypharmacy, so 2 or more psychotropic drugs as well. And this plot shows the people with intellectual disabilities in green and the general population in grey. And for each type of polypharmacy, we see that there's this higher prevalence in the intellectual disabilities group. So adults with intellectual disabilities were 1.5 times more likely to be taking multiple anticholinergics and almost 3 times as likely to be taking multiple psychotropics. So it's this polypharmacy that's causing the really high anticlimactic burden that we see in our intellectual disabilities group. When we examined the individual drugs and their level of risk, we see that the most commonly prescribed anticholinergic medicines are low risk, so the ones that are categorized 1. But the pattern between the groups is quite different. So the table shows the top 10 ranked anticholinergic prescriptions for the intellectual disabilities group, and then how the general population compare. So for the ID group, half of the drugs are psychotropics, whereas it's quite different for the general population. So we know that the most widely used anticholinergic drugs are low risk, so it's all 1s and just 2 2s, which really highlights that any polypharmacy necessitates regular review. So overall, adults with intellectual disabilities are at a higher risk of anticholinergic burden than the general population, no matter their age, sex, or deprivation area. Anticholinergic burden needs considered at much younger ages for people with intellectual disabilities, but especially for women who are at higher risk than men with intellectual disabilities. And this should really start about age 45 plus. When we look at where this anticholinergic burden is coming from, we've identified several different classes of drugs, probably prescribed by several different specialists. And this is really important to highlight because people with intellectual disabilities are probably accessing multiple different healthcare teams and services. So it really kind of highlights the need to have an overarching kind of a person-centered approach, looking at everything rather than just one specific specialty. So there's a clear need for regular medication reviews, which could address any inappropriate prescribing and reduce the burden experienced by this patient population. A clear limitation to our current data is the lack of indication. So we didn't know which long-term conditions people might have had. So it might be that that individual with very high anticholinergic burden is necessary for good quality care. It's what might be best for them to control their epilepsy or anxiety and stomach reflux. And it's just worth noting that not all polypharmacy is bad. So, for example, there are 4 standard prescriptions for preventing future heart attacks, for example. However, the overuse of anticholinergics could be what's contributing to some of the health inequalities faced by people with intellectual disabilities. And this is something that I'm hopefully pursuing with the next set of work, looking at the multimorbidity, the indications for these prescriptions, and having a bit more of a broad focus, and hopefully providing evidence beyond the anticholinergic prevalence in this population, but what it actually might mean in the long term. So thank you for your attention. I'm happy to take questions if anyone has any.
Thanks, Laura. That's really interesting. A few more people have joined now. I'll be pleased.
Yeah, I had a few pop-ups, but it's such a small thumbnail, I don't really know. So
Yeah.
well, I think this is going to be shared. My details are all there. So if anyone has a question, I'm happy to take it in whatever form and whenever as well.
I wondered just if you thought any more about why it was why the anticholinergic burden was so much higher and worse in people with learning disabilities.
Well, I think it's quite tricky because, I mean, it might be necessary. So we know that about just under a third of people with intellectual disabilities also have epilepsy. So the prevalence of anti-epileptics is going to be high. But it might be the case that they're on 3 or 4 different anti-epileptics, and actually you could probably reduce that to 2 or 3 and then reduce the burden overall. But it's things that it's tricky because it's not really monitored. And I think in 2015 there was a big push to stop the overprescribing of antipsychotics in the intellectual disabilities population in response to challenging behaviour. And there's big government initiatives and NHS initiatives to reduce this certain type of prescribing. But I think it's really tricky because with mental health, there's a lot of different factors at play. So for the overactive bladder patients, I think it's a more straightforward switch to go from one drug to another and just remove the anticholinergic focus. Whereas for people with intellectual disabilities, there's a lack of specialism there. So I think GPs, when faced with things, they're going to be a lot more reluctant to change medicine that's prescribed by a psychiatrist or another specialist, for example. But it's like it takes breaking point. It takes people to be hospitalized, and the pharmacist involved in it described it as going on a medication holiday. So it might just take this sort of extreme crisis moment to kind of establish what's going on, what can we do, how can we improve it, and being realistic about that as well. And let's face it, COVID hasn't helped anything at all. And medication reviews and yeah, I doubt that they'll have been happening as often as they can. But I know for the moment in the annual health checks for people with intellectual disabilities are up and running again. So hopefully, this is the sort of stuff that should be captured under here, but I don't know about the reality of that. Shall I hand over to Liam now?
Yeah, Laura, it was a great presentation. I don't have any questions, but it was very well communicated and clear, so thanks for that.
Thank you very much.
We're a very small group. I don't know if anyone, it's my first time at this meeting. Is it usually a small group or not?
No, I think there's usually more. I don't always make it. I know, sorry, Liam, I'm not sure if you want to still present or if you want to hold off to another time. I'm not sure really what's best, because it does seem like I presented a couple of months ago at this, and there was definitely.
I think normally there's a reminder that goes out, but it wasn't this time.
No, I've just texted a colleague actually, and she was saying that she didn't know about it. Wasn't in her diary, but
yeah, I mean it might. Yeah, I mean,
Laura's already given hers.
If no one's too bothered, I might not. I mean, if I don't imagine anyone's joined this call to hear about this study particularly, but you know, given that
of course we'd love to hear about it. I'm sure it's very important, but yeah, if you'd rather, it seems it'd be more useful to present it to a wider group, wouldn't it?
I think so. Yeah. So if people aren't bothered, I'll maybe just pass that back to Margaret. And
I'm sorry, because you've both
no, it's
obviously
fine.
gone to a lot of effort to put together a presentation for
Well,
today.
it's not your, I mean, it's the, you know, the people that have turned up are the virtuous people who've shown interest. So it's
I know, but
I'm a
still,
bit,
it's, you know.
I mean, Joanna works with me, so she'll hear about this. Hamish, I don't know about your background, but I mean, if anyone is researching this topic and is really keen to hear it today, I'll do it. But otherwise, I might just try and do it another time.
That's fine. It's fine, Liam, whatever you prefer. I was interested, and it's interesting. I'm glad I still heard yours, Laura, because that is useful for work that we're thinking of doing, maybe around pain medications and so on. So, but I'm sure yours would be just as interesting, Liam. So
yeah. I'll let Margaret Naismith know that there was only a few of us. So
yeah.
we'll do it another time. Okay.
Okay.
Thanks, everyone. Then.
Nice to see everybody.
See you.
Thanks,
Take
Laura.
care. Bye.
Bye.